Welcome to the show where we share the stories of the many who intersect with our healthcare system but are rarely heard from. My name is Kevin Poe, founder and editor of Kevin MD. Today in the show, we have Mallika Sekhar. She is a hematologist-oncologist in the United Kingdom, and she co-wrote the Kevin MD article, Fear of Vaccines Grows with the Need for Medical Ethics. Mallika, welcome to the show.
Thank you, Kevin. Lovely to be with you.
We'll get into your article in a little bit, but first off, can you share your story and journey to where you are today?
Yeah, so I was born and brought up in India, in the south first, and then in Bombay, now Mumbai. And I came to England, to London in '87. So I've lived there pretty much half my life. I spent a little, about a year, just short on a year in the USA at NIH for a bit. And I'm now a consultant in blood diseases. And I did this essay for Kevin MD, really out of my interest in how people think about, especially doctors, think about and take decisions, clinical decisions, when there's a lot of uncertainty about an evolving medical situation. So that's what brought it about. And then when the vaccine-related thrombosis happened, which is within my own field, I paid more attention to it. And it raised so many problems of clinical, but also ethical nature that I thought it resonated with a number of other issues related to COVID. That's why I wrote that.
All right, and we're going to certainly talk about that article in a little bit, but I don't speak to many physicians from the United Kingdom. So tell me some of the challenges that you face practicing hematology-oncology in the UK.
I suppose I would say when I first came to this country, one of the most important statements that I remember in my first week of working is I took a sample down to the lab, and then the nurse who was there with the patient where I collected the sample, she said, well, at least the system works. And so I think that message, that statement by that nurse has always lived with me. And I think the system works is something that the country takes very seriously. And to an outsider, it might seem actually a very impersonal, unresponsive, uncaring system, because it's not that it's catered to the individual. So that was the past when I came in '87. Increasingly, in the last 10 years or so, it's become much more patient-centered, patient-focused, individual-focused, such that we're able to pay attention not to the system working alone, but also to actually what an individual would need and would want within the constraints of what the system has. So the greatness and the shortcomings are two sides of the same coin, that it's a system and it can fail you if you are not in the right slot, or it can be a superb asset if you fall into the right slot.
We are speaking now towards the end of November. So tell me, what's the situation like from a hematology-oncology standpoint as it relates to the pandemic?
Well, during the pandemic, we had a very effective network of clinicians across the country. And so all the blood cancers, for example, they were, organized, and instructions to patients were given on a very systematic national way. They were pretty arbitrary because we didn't have much in the way of evidence. Now coming into post-pandemic, because we've got a very stable situation here, the vaccine take-up is very high. And so we're now in a position where we are seeing lots of patients as backlog. Patients are very unhappy at having had too many telephone consults and not enough face-to-face consults. So we're increasing the face-to-face consults. We've learned a lot about treatments and how we can modify them either by fewer visits or less intensive. So we've gained a lot of knowledge over the COVID months. And so we're using that in actual clinical practice to modulate treatment better. So it's been really, really busy, and a lot of reassurance has been needed for patients and to the juniors. The juniors have been pretty hard worked through the COVID months.
So let's talk about the Kevin MD article that you co-wrote. It's titled, Fear of Vaccines Grows with the Need for Medical Ethics. Now, for those who didn't get a chance to read your article, can you just walk my audience through it and share the story of why you decided to write it?
Well, it's about the fact that people got thrombosis of blood clots in the veins in the head or veins in the abdomen, and as an unexpected, completely unanticipated consequence of the vaccine, and particularly the AstraZeneca vaccine. So the AstraZeneca vaccine has had a very checkered career, really. But in the UK, people were pretty pragmatic about it. And what struck us as co-writers was the fact that people were so worried about this unexpected consequence that in their actions, they expressed their fear. They went to casualty departments and they declined to take a vaccine. But at the same time, there was a reluctance to accept this spoken about publicly. So my colleague who would speak about it to say, oh, 5 patients have been admitted with this kind of a problem. Should we be questioning the vaccine? Got a stony silence facing her. So that became a matter not just of clinical management, but of ethics of how we deal with the public interest as opposed to a private need, and how people can be shoehorned into categories just on the basis of how they communicate and what they communicate. And a corollary to that might be now the need to vaccinate children. So are we vaccinating children to protect the adults? And that might be completely valid, but it's a question that needs to be asked. And to ask that question is no bad thing. So the nuance is, therefore, how do we ask the question? Is it permissible to ask the question? And how do we deal with the aftermath?
So give us a sense of the background of the Oxford-AstraZeneca vaccine. So as you know, this vaccine isn't even approved in the United States. So give us a snapshot of how often that vaccine is used in the UK.
So I'm no expert on vaccines, but what I've in practice, for example, a lot of us healthcare workers started off as the first tranche of vaccine recipients. And a lot of us got the Pfizer vaccine at the outset. The AstraZeneca vaccine was rolled out to the wider community. So lots of people got the AstraZeneca vaccine. Once the thrombosis issue became known, then there was an age cutoff that was defined such that below this age, people will only receive the Pfizer vaccine. And that age cutoff varied in different countries. In some countries it was 50, some was 30. And so that has also changed over time. So now in the booster program, most of us are now getting a Pfizer vaccine for the booster program. The other politics about AstraZeneca, America hasn't endorsed it. The FDA hasn't approved it because of the nature of the data, which was not entirely clear. But it's also interesting that people have used the variance in data and the unexpected findings, which you never planned for when you designed the study. They've actually used it to develop the science as goal. It's a very pragmatic approach to science. So in that way, I think the UK approach to developing vaccine science based on the failures of AstraZeneca has been tremendous. Politically speaking, India manufactures AstraZeneca vaccine, but actually it was not recognized even by the UK, nor by the WHO. WHO has only recently recognized it, and the UK only recently recognized it. So there's lots of connotations of the, not least that it's still not FDA endorsed.
What's the prevalence of thrombotic events from the AstraZeneca vaccine?
Very rare, vanishingly rare. How vanishingly rare seems to be changing, 1 in a million, but then some say that it is more frequent, but it is along those lines. As we've gone along, since the original publications, more and more reports have been made, but also equally fewer people are receiving AstraZeneca. Then there were some reports of the Moderna vaccine. So it doesn't seem to be confined to these.
Giving out the vaccine, you talk about the ethical quandaries that physicians face. So give me some specific examples of some of these decision points as they consider which vaccine to give out.
Well, the vaccine issue itself is full of quandaries because of vaccine nationalism. And so who has the right and the privilege to receive a vaccine? How should it be equitably distributed? Should a booster vaccine in a country be prioritized over primary vaccination in another country? Because it is about availability. And how much should people be allowed to travel for vaccine tourism? So these are all questions that are coming up. I think practically speaking, youngsters, especially teenagers and increasingly older children, are becoming more vocal to say, why should I take the vaccine? Because it's not something that's going to affect me in a fundamentally significant way. And so there is a lot of voices that are now being heard from the younger people. And we have to pay heed to that as to who is the beneficiary from these vaccines. But I think to me, the most important, perhaps the most important point is through HIV in the 80s, the one thing that the world learned is how to deliver equity of treatment across the world. That was the one useful, really important global outcome of the HIV pandemic, such that people across the world could access HIV treatment, and successfully so, without having to sell their house or, whatever. So having had that infrastructure and the intellectual knowledge of how to deliver it and the society's capital of how to deal with delivery of this, implement this, it seems really perverse that we haven't been able to translate those lessons into vaccine equity for COVID, which everybody, because it's such a rapidly evolving pandemic, vaccine equity was considered actually, and is considered, a really top priority. So that's something, it's a conundrum that I haven't quite understood.
So you mentioned vaccine nationalism as a potential cause for the problems that we face with vaccine equity. Are there any other reasons why we're having problems with vaccine equity today?
There is a lot of anti-vaxxers or vaccine deniers, vaccine refusers. So even within the low-income countries where people have made a lot of effort to deliver vaccines to a community, there's been a poor take-up.
Mm-hmm.
And within Africa, for example, there's a big South-to-South collaboration. So if country A has excess stocks, they would send it to country B. And so this transfer of surplus stocks has been useful to deflate some of the wastage. But poor take-up has spread very widely. And that has complicated matters when it comes to poor equity of delivery. It's very hard to trace all of these things, but it probably began as a politico-financial kind of a deal where people wanted to stock vaccines and charge other people, and raw materials were not sent. I mean, all of these are all fundamentally financial deals. But then that soon translated into society's suspicion of everything. And that suspicion soon translated into poor acceptance of vaccine. So I think we're probably getting past that third stage into something better than where we were, say, 4 months ago, I feel.
We're talking to Mallika Sekhar. She is a hematology-oncology physician in the United Kingdom, and she co-wrote the Kevin MD article, Fear of Vaccines Grows with the Need for Medical Ethics. Mallika, as we hopefully transition into a post-pandemic period, what do you feel are the remaining challenges when it comes to vaccine equity?
I think it's about the nudge factor, being able to persuade people using the right language and vocabulary that this is actually something useful. But then going beyond, and the second is, of course, to be able to distribute the vaccine effectively and not waste it as we are at present. But I think going forward, this is a model. So we had a big crisis with Ebola. Luckily, Ebola virus never spread as widely as this virus has spread. But how we deal with a disease in a community, how the community deals with the dead, how we reconfigure our ecosystems, I think these are major questions. And the world has got to address these really, really carefully, because we've got a climate crisis. We've got a huge inflation in so many countries, perhaps not in USA, but practically everywhere else, the inflation is huge. And so combining these with further pandemics, I think, needs a very self-aware solution from politicians.
So you mentioned vaccine hesitancy, which of course is a problem in the United States. Can you comment on the scope of vaccine hesitancy in the United Kingdom?
Well, we have less vaccine hesitancy than many other countries. The delivery was very smooth. And one of the biggest things that happened with the vaccine delivery, as opposed to a lot of the COVID testing delivery, is that the NHS took it upon itself to deliver the vaccine program. And like I said at the outset, the NHS does some things really, really well. And the vaccine delivery was a successful rollout. It was done really slickly. People could just go get it done. So for a variety of reasons, we haven't had much, but we did have a huge hesitancy in certain sections of the population, some of which were ethnic minority populations, some of which were people who were young women, young men, and so on. Even healthcare workers, many doctors declined. 25% of doctors at one time declined to have a vaccine. So the government, I think, there's been a lot in the media where and in religious groups where people have gone out of their way to dispel myths and spoken to their own kin and networks. So it's not as if I'm being spoken to by you as an American, but I'm being spoken to as my friend in the street or whatever, somebody who's considers my welfare as important. And so I think that's really struck a chord, and it persuaded many people of the middle ages and the older ages to change their practice. For the youngsters, I think the fact that you could go clubbing, you could go to the pubs more easily if you had a vaccine, I think that's changed that dynamic. For the healthcare workers, it's going to become mandated that people have to be vaccinated. Otherwise, they would have to move from their jobs. And so I think that's going to change it.
And my final question, what are some of your take-home messages that you want to leave with the Kevin MD audience?
Well, I think the main message is, how do we deal when the science is uncertain? How do we deal with diseases as doctors when the science is uncertain? That's always been my research interest. I've made some podcasts around HIV and hemophilia. So in the 80s, people with hemophilia got HIV and AIDS because of their treatment. So how do the doctors think? For 4 years, people didn't understand what was going on. So how did you take treatment decisions? How did you counsel your patients? What do you tell your patients? And how do you feel about it now? So those are the questions that are the subject of my podcast, which is on Spotify and Apple and so on. It's called the Bitter Pill Podcasts.
Mallika, thank you so much for sharing your time and insight. And thanks again for being on the show.
Thank you, Kevin.